Okay, we'll go through a first case here, and this is something sort of typical that we would run into in an emergency department setting. A patient suffers a motorcycle accident. He's an unhelmeted driver of a motorcycle that was witnessed to have gone off the road. The patient was found at the bottom of an embankment. He was alert but confused at the scene. The medics report a Glasgow coma score of 13, and they report that he was complaining of some abdominal pain. On exam, he's confused with a GCS of 13. He is a patient within our hospital system, so we were able to go in and find out that he is on a reversal agent. He has a history of factor V Leiden with previous DVT and PE, and he's on rivaroxaban 20 milligrams daily and metoprolol. He's unable to tell you if he takes his meds regularly or when his last dose was because he's a little bit confused right at this time. BP is 110/60, heart rate is 90, and when you look at that heart rate, what's the key thing? The key piece of his history that makes that heart rate a little deceptive? Yeah, he's on a beta blocker, so it's not necessarily going to be representative in the same way as it would be otherwise. Pupils equal round, reactive to light. He's got a scalp laceration, no other spine problems. He's got slightly decreased breath sounds on the right. His heart sounds are normal. His abdomen is tended with bruising in the epigastric region and the right upper quadrant, and his pelvis is stable. He's got multiple superficial abrasions, and again, he has a non-focal exam. And unfortunately, the handlebars, and this is a real case, the handlebars are what ended up hitting him in the right upper quadrant. That's sometimes problematic. We see that even in bike riders. So, is this guy really anticoagulated? And how can we tell? We kind of talked about this before, but we'll bring those points back together.
Yeah, so by history, he's on rivaroxaban. If he's compliant, then he's anticoagulated. If he's not, then he's not. And I don't know that we have an actual way of knowing for sure, besides maybe some testing. And you can check a PT. We don't have TEG at our hospital. I'd like to get it, but the PT would be elevated if he was therapeutic taking rivaroxaban.
And again, TEG is one of those kind of things that it's going to vary institution to institution whether or not you have that available. And there's a huge push within our trauma system, our trauma people, to get that available for us so that we can have a good idea if this person or anybody for any medical reason is anticoagulated. So again, PT is the most sensitive for rivaroxaban, but less sensitive for apixaban and edoxaban. And if you have a totally normal PT and you're on rivaroxaban, there's a pretty good chance that you're not anticoagulated. But again, if that's something you can get in real time, that may be an acceptable thing for you. If it's not, it's going to be problematic, and it's not very useful when we're talking about apixaban or edoxaban either. So this is TEG. And this is not going to be a lecture about TEG, but basically what this tries to tell you is the presence of which component of your clotting system, so to speak, is problematic. And this can pick out an anticoagulant fairly quickly. And it has to do with how these curves are generated and what they look like. And you can tell based on, and you have to study this stuff a little bit and read a little bit more about it, but you can tell based on the angle of rise of that curve and the thickness of the curve whether or not there is an anticoagulant in the person's system. And if I can get that test in 5 minutes at bedside, I'm probably going to use that. But until that time, I'm going to be in a position where I'm going to have to believe what the patient's history says. Especially in this patient, you go back and you say this guy is he has factor V Leiden, and this guy may likely be on anticoagulants forever, and it wasn't just a 6-month thing. They forgot to take the agent off. So what if you did a fast scan and it looks like this, and what this tells us is that it's normal. Very fast is negative. At least this portion of it is. Let's say that all the other components are done and that they don't show any blood. And what if you do a head CT on this guy and it looks like this? And let's just say that this is representative of all the cuts. There really is no bleeding. And his belly CT looks like this. I'd be surprised if that were the case. Is this somebody that you're, let's say you called your pharmacy, the pharmacist is down there, they're ready to get this stuff mixed up. After seeing these findings, are you going to reverse this guy? Yeah, this is one of the easier ones. Yeah, this is someone who probably would not be reversed. And do you have any thoughts on that?
I wouldn't reverse him either.
Yeah. So what if you had a little tiny hematoma in the liver, and let's say you did go on and you found this guy's PT is significantly elevated, or someone comes in and says, yeah, he takes his medication all the time. What are we going to do with this picture here clinically? What do you think?
So to me, these are the perfect patients that are salvageable if we reverse them early. This is like, the person that comes in walking with a small intracranial bleed with a Glasgow coma score of 13 or 14, their mental status is good, but they're on a DOAC. These are the ones where we can make a significant impact if we can reverse them. I would reverse this person in a heartbeat.
And the reason I put this particular case up here is because this is the stuff that's managed non-operatively, at least in almost every institution. These are small bleeds. But if you decide, I'm going to do this in consultation with my trauma surgeon, you had better think about re-imaging this person in a reasonable period of time to make sure that if you're going to not use the agent, that the significant complication of an increase in hematoma doesn't happen. So you really, if you're going to make those decisions and be bold, make sure you follow closely. This is not somebody you just put in your observation unit and ignore.
I think you can. This guy's a big risk for thrombosis because he's a factor V Leiden guy with proven DVT. Potential is going to be stuck in bed for a couple of days. So if he had none of those factors and he had a DVT 2 years ago, I would reverse the guy immediately. But in his case, I probably make a clinical decision to repeat a CT scan in 2, 3, 4 hours. So I think you can argue it both ways.
And I think that's why we're here. I think that's a reasonable thing. And something else that is not terribly uncommon is to say, okay, I'm going to reverse this guy now. We're going to watch him, and then maybe I start him on something else, like maybe I anticoagulant him on heparin for a period of time, and until I can be sure that it's just as simple as turning the drug off. And so you can manage this in a lot of different ways.
There's no right or wrong. I've got factor V Leiden and I'm anti-HFR homozygous for hyperhomocystinemia. I'm on Riva, 10 milligrams daily for the rest of my life. True story. If this was me, please reverse it and get me up and walking so I don't get a clot.
Okay, so we kind of talked about that. Now, what if you see that? Again, this is not the difficult case where you really have to ponder too much. Not only is he going to the OR, probably, this person has a very high mortality. So how would you classify this bleed? Okay, major life-threatening bleeding. That makes complete sense. We have a patient with an intracranial hemorrhage. Coagulation tests are not back. Where are we going to go with this? So again, we've touched on a lot of this. The answer to the second question is, there's a better question than the second question in my mind, and that is why, in particular, is the anticoagulation not restarted in an appropriate time frame? I can't say that I'm going to be the one who's going to make the decision to start and restart, but the question is, why does this happen? And I asked a lot of our hospitalists, and I asked a lot of people in our institution, and it comes down to, well, I better call my neurosurgeon on this, or I better call my GI doc. And then the GI doc says, well, let me talk to Hem-Onc. And Hem-Onc says, oh, well, let me get back to the hospitalist. And pretty soon, nothing happens. And that is the law of the Swiss cheese holes lining up. And one of the ways to combat this is, especially in your system, is, and I would suggest this if you're going to be involved in guideline writing and you have the drug, have your EMR alert the hospitalist or the admitting doc. This patient was on an anticoagulant for a reason. Is it time to restart anticoagulation in a timely fashion? I think that may be a way that we can mitigate that, and that's something that we're definitely going to be putting into our guideline. Make the EMR do its job, other than driving you crazy. Something to think about when you're involved in guidelines or involved in any decisions. To use a drug or not to use a drug. Remember, you are the clinician, you are the person seeing the patient, and oftentimes as emergency physicians, although I preface this by saying this is a nerdy topic, and you really have to be interested in this and read a lot about it to really, really get to a really good understanding. But you might be the only person in that hospital who does understand this. And I'll tell you, people say, well, ask the Hem-Onc guys. You call the Hem-Onc people, and sometimes you get that anticoagulation nerd. Other times you get the guy who specializes in one particular type of leukemia or maybe sickle cell or something like that, and they don't really know. And they've said right off the bat, we don't want to be involved in making the decision to use this drug or not to use it in real time. So if your guidelines are going to defer to somebody else, make sure they're deferring to someone who actually understands and has a stake in that game. So the what if? What if this was the patient? Again, oh, that doesn't look like too bad of a bleed. This is a contusion that in 24 hours blossoms into a monster. And if that person's anticoagulated, that's going to be a problem. So is that by itself? And now if that's what it looks like 5 days later, it's a different story. But let's say that's the initial CT. Yeah, that has the potential to become something a lot more. And again, if it's days and days out, and it looks like that, it's going to be a different prognosis. And we're not going to be asking the question about reversal at that time. We have a patient with intracranial hemorrhage. Coagulation tests are not back. We talked about that again before. We talked about this. When would you restart anticoagulation on that head bleed?
So this is kind of what we're seeing in real life, is usually about 3 to 4 weeks out.
And in some people, that's going to be totally okay. Other people, it's going to be a disaster.
We beat
Pretty
this.
much hit this one. We've given this question an intracranial hemorrhage.